Welcome back to Inside Industry Podcast, Season 5, Episode 4, your ultimate guide to the inner workings of the pharmaceutical industry. Get ready for exclusive interviews, insider tips, and expert analyses from the leading minds shaping the industry. We're here to answer your questions, so don't hesitate to comment below or reach out to our social media accounts. Get ready to dive into the fascinating world of the pharmaceuticals. So let's begin with this episode.
Hi, everyone. Welcome back to Insight into Industry. My name is Gautam Venkatesh, and I'm a third-year pharmacy student at the UNC Eshelman School of Pharmacy. Today, I'm joined by Dr. Matt Ransom, who's the Director of 340B Pharmacy Services at MAHEC. Dr. Ransom graduated from the UNC Eshelman School of Pharmacy and continued on to receive his master's from the UNC Gillings School of Public Health. Thank you for being here today, Dr. Ransom.
Sure.
And so just for our viewers today, today's episode is going to be a little bit different, moving away from industry. We're going to be talking about 340B medications, which I think is really crucial, and Dr. Ransom will touch on how it can help the underserved and why it's important to learn today. So to get us started, Dr. Ransom, could you kind of describe your career journey, what has been so far, and kind of how you ended up in the position you are in today?
Sure. After graduating from pharmacy school, I went into a PGY1 first-year residency in ambulatory care. I did that work in Western North Carolina at Mission Hospital and Mountain Area Health Education Center, clinics in our area. And then after the residency, there was an opening at a medication assistance program that's associated with the hospital, Mission Hospital. At that time, Mission Hospital was a disproportionate share hospital or DISH hospital and eligible for 340B pricing in a hospital setting. And the program, the pharmacy I worked in, was a charitable expression of the use of that 340B dollars in that setting. So it's for both. It was a community-based program in a department. It was community-based services, elder care services, diabetes education center, nutrition, exercise consults, all centered around community health and wellness and mobile health events, going to parking lots, doing blood pressure screenings, helping kind of connect people to care. It was the whole effort was surrounded around that, and it was that time. It was one of the ways that 340B savings helped patients access care within that setting. And then after working there for a number of years and shifting around within positions within the medication assistance program, I came to MAHEC, which would be another way of working around and within the 340B environment. But rather than just portion and share hospital, MAHEC's an FQHC, federally qualified health center lookalike, which is another covered entity type for the 340B program. So it's using some of the same interests, skill sets, mind towards community benefit, public health, and applying some of those systems in this setting as well.
Wonderful. That's great to hear. So you kind of talked about the big picture of what you do. What does your day-to-day kind of look like at MAHEC?
My day-to-day is administrative at this point. So it was MAHEC is new to being an FQHC, and so with that comes a lot of the beginning setup of the 340B program. What the heart of a 340B program operationally is around compliance and audit and making sure that the program is implemented in the way it needs to be implemented. So my day-to-day is developing policies and integrating workflows and systems within departments and areas at MAHEC and making sure that our compliance is in order. And then when that baseline is running well and we have our our monthly systems in place for making sure all that is okay, then you use that revenue to benefit and develop other services within the organization. So we're doing that now. I mean, we've been doing this for 2 years. We have a good solid base, and we're evaluating and always developing kind of new programs. And at the very base function, making sure patients that need care at MAHEC get what they need, the care they need if they're uninsured. And 340B helps give a financial mechanism to do that work in the community. So, what does that look like? It means I'm signing contracts. It means I'm writing policies. It means I'm talking and going to lots of meetings. My kids ask me, "What'd you do?" I fill out forms. I went to meetings. Like that. I mean, that's what it looks like as a task. But what it is leveraging the benefits of a federal program to benefit your local community, which is one of the amazing things in my mind about the 340B program.
That's great. And I know some people listening actually won't. I personally didn't know too much about it, but would you mind explaining kind of what 340B medications even are and how your pharmacy utilizes?
Sure. So 340B is part of the Public Health Services Act, and it's a federal statute, and it's a statute that helps establish a discounted pricing on medications that are used in specific outpatient settings. It's a legal definition, and so it's really important in the beginning to understand what 340B really means. On the surface, it sounds like it's a discount from manufacturers on medicines, but the way the law is structured is it sets up this discount in relationship to the Medicaid program, and so manufacturers that participate in Medicaid programs also offer a 340B discount. When I talk about compliance and audit within the 340B program, one of the most important parts of that is, since that discount is coming from manufacturers within this system of being able to have this benefit, the manufacturers can't pay a second discount on the same medications in the form of a Medicaid rebate. So there's systems in place to avoid that from happening, and that's the setup process. And so really thinking through 340B is a statute, and then there's lots of other. It's called the Federal Register. There's lots of other sort of FAQs that clarify details around the operations of the 340B program that are important to understand. But at its most basic function, it's a federal law that establishes a discounted pricing program for certain covered entities, and it allows those covered entities to use that savings to expand their ability to care for low-income uninsured patients in different communities. And so the strategy behind even establishing that was to allow hospitals, qualifying hospitals, disproportionate share hospitals, which means that over 50% of their patients, it basically means that there's a commitment for caring for patients regardless of their ability to pay. And then same is true for a variety of covered entities that also are qualified under this law. So that availability carries a lot of responsibility in being able to use the program correctly. And so that's the work of the 340B program, is making sure that it's being used appropriately, and there's the records to show that it is, and then using those savings to go back to patients. So that's the heart of the 340B program.
Gotcha.
And lots of nuances around how it's administered. If a person really wants to dig in and learn about it, one of the best places is through a group called Apexis. They have a thing called 340B University. Apexis is called a prime vendor program, and as part of that federal statute, it establishes a group, an organization that helps administer aspects of the 340B program. And they have a thing called 340B University. It's an education series, so people can learn a lot about the 340B program through Apexis, APEXUS, and it's really worth a person's time to get their first pass of baseline knowledge around the program that strikes you as interesting.
Awesome. No, thank you for that explanation.
Yeah.
Resources for that. So kind of my next question leading off of that is, how's the MAHEC pharmacy kind of structured, and how's it different from traditional community pharmacies? I know you kind of explained it to me a little bit when we met in person.
Yeah. I mean, there's going to be a lot of variations on how pharmacies are structured within these kinds of settings. The way the MAHEC pharmacy is set up is it's a retail pharmacy that is owned by the FQHC. Sometimes the phrase covered entity owned or in-house pharmacy will be used to describe that, when the pharmacy is owned by the covered entity where it's at. And so we're on the campus of our clinic, right on the separate building, but same campus. So patients can walk over, drive over, come over fairly easily from their family medicine visit, internal medicine visit, and get prescriptions filled here. The people are sitting. And so we're an open model pharmacy, which means anybody can use our pharmacy if they would like to. They don't have to be patients of our FQHC, but with that comes a method around making sure that we're using our 340B priced medications appropriately only for eligible patients. So we have systems in place behind that to make sure that that's happening. But we also have patients that are uninsured that come to our FQHC, and we want to make sure we're meeting their needs. And we can do that in a variety of ways. There is sliding scale fees that we have and can implement for purchased inventory, but there's also methods we use around charitable inventories of medicines that are available to pharmacies like ours, that where it can be made available to patients at no charge if they meet eligibility criteria. So we have a variety of different inventories where we'll dispense from those inventories to patients that are uninsured and under a certain part of the federal poverty limit at no charge. And so between those inventories and our 340B program, we can develop strategies and availability of many different meds to meet people's kind of chronic disease management needs. The other unique thing about MAHEC is we have pharmacists that are embedded in clinics. And so we have pharmacists in clinics. We're working closely with physicians. We have our retail operations, and all of our systems of communication are integrated. So say a patient gets seen in the clinic, it's a medicine that they can't afford, message can be sent to us right then, right at the point of care, where I'd like to do this therapy for a patient. They can't afford it. What do? We can kind of intervene in the moment, suggest what we may have that's therapeutically similar, and prescription comes over. The patient's not having to. It reduces the confusion potentially, right? They can just walk over from the clinic and then the medicine's here and we had a conversation and we can teach them what to do. So at the heart, like I think what makes our model different is yes, it's med access, but it's also about clinical care and integration of that clinical care with workflows that are happening on the outpatient setting. And that part makes it like, I don't know, really fun and really satisfying because people are not getting bogged down in the confusion of working a system. They're just able to get what they need, understand what the therapies are, and move towards feeling a little better quicker, which I like. That part's great.
Yeah, that part definitely sounds good. But so what was the process? What does the process look like to become an FQHC lookalike? Like, what is the timeline?
It's huge. I mean, that's a huge question, and it's a years long process. And so you would HRSA, HRSA, health, the Human Services kind of division, the federal government has whole complex pathways about how does one become an FQHC. And so FQHC status is the first large step. But even after becoming FQHC, the 340B program is separate. They don't come they don't come, at the same time. You establish your group as an FQHC or whatever your covered entity type is, and then you apply for the 340B program, and then that's another series. And that can take 12 months. I mean, it's not a fast process, but it's a very structured process. So one can learn it and move through the systems of it and know how to implement a program. And it's not hidden. It's not hidden information. It's all available. It's somewhat complex information. So, but there's communities of people and conferences and interests around doing this work that as soon as you begin to enter into 340B work, you discover all kinds of folks with like anything, right? Pick a topic, there's communities of people to think and communicate about it. The same is true for 340B pharmacy work.
I see. Okay. So would you say, would it be at all possible? I know it would be extremely difficult, but could a community pharmacy or like an independent ever qualify themselves as an FQHC lookalike? Or is
No.
that no?
No, being an FQHC lookalike means that you're providing certain required services to patients. And the idea is that the health of communities are improved and there's a standard about what's considered that needs to be available within that care delivery system for a patient. So that would include, labs and um, the monitoring and certain access to certain levels of care. I mean, really, the standard of care is what you would receive in a primary care setting. So a pharmacy can contract and be part of the work FQHCs do, and that's another very common model, is that you have a community independent pharmacy that's, they're doing their work, they're working, doing good work in their community. There's a local FQHC. Many of the patients from that FQHC come to that local pharmacy to get their prescriptions filled. There's contract arrangements where that pharmacy can qualify in collaboration with the FQHC to purchase 340B medications. A covered entity is purchasing it, but the contract pharmacy is getting the shipment, and they're dispensed for patients of that FQHC in that relationship. And then there's negotiations about how the savings is used within that framework. So that can happen. Also, FQHCs can open their own pharmacies, and that's also what often will happen too.
Gotcha. Interesting.
But a freestanding pharmacy by itself is not a covered entity. Covered entity would include, like I mentioned earlier, disproportionate share hospitals, FQHCs, FQHC lookalikes. There's some health departments have designation around reproductive health. There's infectious disease designations in those settings. There's black lung disease is a type of illness that people that work in coal mines will get when they're breathing in the dust of coal. So think Appalachian regions. That's another qualifying kind of clinic type. There's critical access hospitals. There's more. Maybe there's like 8 total. But anyway, so it's all very defined, specific type of criteria around that.
Gotcha. Okay, interesting. I kind of wanted to draw back a little bit and focus more for the students. So I did mention at the intro that you did receive your master's in public health.
Yeah.
Would you recommend a dual degree to current pharmacy students, and how has this
depends on your interest. I mean, it depends on what's important to you, how you want to spend your time in your work, how you want to organize your approach to work. But if you have a mind towards thinking about how systems in healthcare worked and how you could impact those systems with efforts of change, a public health degree gives a good way of thinking about what that might look like. The nature of public health is we're not thinking about individuals, and I think we are in pharmacy school trained to think about, rightly so, the patient in front of us, right? And so that's our focus. We're learning deep knowledge around disease states and therapy and individuals, and in an outpatient setting and patient setting, how do we interact well with people to help move them towards health outcomes? But then as you do that work, and if you're like interested in that idea of repeating themes, like why is this group, why is this population, why does this theme repeat around illness? What does it mean that X is happening in this community, and all these folks are experiencing the same negative outcome? What's underneath that? Then you're kind of reaching into public health, right? And thinking through, what does that look like in that setting, and what do I do within that setting? The benefit of public health is also it's not a specific discipline that you apply to one training, right? So it's not like you go to public health and then you're a thing that public health is only, right? Like pharmacists have public health degrees, physicians have public health degrees, community health workers have public health degrees, RNs have public. So it gives you like a connection across disciplines with that sort of common understanding, which I think is another nice part of it. If it's a field that interests a person. So yeah, do it if it strikes you as useful and what you're concerned and interested in. Don't do it for any other reason.
Yeah, that's so that's all the main questions I have for you. We kind of like to end every podcast with just kind of what is one piece of advice or insight that you would give to pharmacy students that are interested in doing what you do? It can be like extracurriculars, pursuits, skills to work on, etc.
Yeah. work in the communities that you care about with the people that you want to be part of and learn from, grow with, and like really think about what that means. And then if you're in healthcare, then these are systems that can help support that further, right? I mean, that's the nature of this work, is it's taking a complex healthcare system, using some of the resources and wealth within that system and helping it go towards communities in need. So if that's and to for that to feel like it matters a lot to spend time with people that are in need. Go to health fairs, go to community events, pay attention to, need in your communities. And then, it's like, oh, okay, this is what I can do about it.
Gotcha. That's great advice. Well, thank you so much for being here, Dr. Ransom, and for taking the
Thanks.
time to talk on our podcast today.
So it's nice to talk with you. Thank you for approaching it this way. Bye.
Thank you again for watching our videos. Make sure to hit that subscribe button and turn on post notifications to keep up with our day in the life content and also other podcasts. Feel free to comment and reshare our content to other pharmacy students interested in the pharmaceutical industry. Thank you again for watching, and we really do appreciate your support. Stay tuned for our next episode next Monday.